All right, so welcome to our Dental Public Policy 101 webinar session in a pre-recorded format. Thank you for watching and coming out. We're just going to start with a brief introduction with each speaker, giving about 1 to 2 minutes for allow them to quickly introduce themselves, as well as kind of just giving your unique perspective and view on what Canada's current dental policy situation is. You're welcome to interpret it however you like. And then we'll start getting into some of the questions that we've formulated that are a little bit more specific related to dental policy. So I guess we don't need to follow any specific sequence really, but you're welcome to kind of chime in as a thought comes to you. But I guess we can start with Dr. Brondani, just how I'm seeing the sequence on the screen, if that's okay. Just give a brief introduction of yourself and kind of your perspective on Canadian dental policy, if that's okay.
Sure. Hello, everybody. Good morning, good afternoon, from those from the West Coast to the Montreal part. So this is quite a nice event. We are getting a lot of representation here. So I am a foreign trained dentist from Brazil. I've been in Canada for about 20 years now. I do practice in private practice, but at the same time, I work at university as my main job, if you will. So for me, when I think about public health, it is a little bit with different hats. One is by being a dentist from Brazil, which has a strong public health focus, which we can discuss as one of your questions. And then coming to Canada, which was very surprising to me to know that dentistry or dental care is not part of the public health care system, which I thought it was. But that's 20 years ago, so now we understand a little bit more. But one thing that I would like to start perhaps is, yes, it's framed as dental policy, but I would like to move away from the dental aspect and perhaps call oral health care policy, because dental, it gets to the teeth, and I think we have to start thinking broadly about, general health, oral health and the connections there, and then perhaps to consider a more holistic approach to oral health care instead of dental. So that's my one take there. And the other one is, as I'm in BC, and I know that I have my colleague here, Bruce Wallace, as well. BC has a different or its own dental policy or oral health policy, which we'll explain a little bit later. But I think we can do more as dentists and as healthcare providers and as a wealthy country such as Canada. So I will stop there. Thank you.
Thanks, Dr. Brondani. I guess we'll pass it on to Dr. Doucette, who I see next on my screen. That's okay, just a brief introduction and your perspective.
So my name is Brandon Doucette. I'm a dentist practicing in Newfoundland and founder of the group Coalition for Dental Care, which highlights kind of the shortcomings of our existing dental care system and kind of what we see as a path forward. So I was really excited to get to talk on this panel. So to start, I just want to highlight some of the consequences and how poor oral health, there was kind of the consequences of that go beyond our mouth. So poor oral health results in chronic inflammation that can cause or worsen many general health conditions like diabetes, like heart disease, aspiration pneumonia, as well as many others. And you can imagine other effects of poor oral health as well. So if you can't chew, it's hard to have a nutritious diet. If you're living with pain, it's hard to sleep. Also, if you're missing front teeth or if you have visible decay, it makes it very difficult to interview for a job. So all of these things can come together to exacerbate the cycle of poverty for people. So when we take these consequences in play, we need to take that into account when we look at access to dental care in Canada and how we're doing from a public policy standpoint. So given that, we can look at some statistics and say about 1 in 3 Canadians lack dental insurance, and over 1 in 5 avoid the dentist each year because of financial constraints. And if we look at that, in my mind, we're not doing very good when it comes to public policy towards oral health. And I think we have a lot of room for improvement.
Awesome. Thank you so much for giving a nice kind of preface of the situation and some good statistics to lay the foundation of our discussion here. I guess next we'll pass it off to Dr. Allison, who I see next on my screen.
Hi there. So my name is Paul Allison. Thanks very much for the invitation to participate in this discussion. So my background is I was trained many years ago as a dentist in the UK. And I trained, then I got trained as an oral surgeon, and then saw the light and decided I wanted to move into public health. And at that point came over to Quebec about 25 odd years ago, and did my PhD and moved into the Faculty of Dentistry at McGill, and I've been there since as a prof. And so my real area of interest and expertise is public health. And I'm very interested in this whole discussion around how we can improve oral health care. And I agree with Mario that we should be thinking of it as oral health care for everyone in Canada. And much like him, I was very surprised to learn that in a country like Canada, which in many ways, compared to my experience in the UK and in Europe, is very European in its approach to many things. Dentistry is kind of out there. It's just left on its own, much more like south of the border, very much in the private sector and free for all. And whoever can get it, can get it. And if you can't get it, well, you're left on your own. And you know, when we ask ourselves, are there any policies? Well, really, there aren't very many policies. It's a mess. And people are largely left on their own. Yes, there are some exceptions to that, but it's an ad hoc mixture that very few people understand. Even those of us who so-called experts wouldn't be able to name all of the different things that are trying to happen and trying to occur, these policies and programs in different provinces. So let alone the oral health professionals who may want to try and serve their communities better, who are struggling to find out how they can do that, and certainly the patient groups themselves. So really, from my perspective, it's the policy. There's no policy, and it's a real ad hoc mess across the country. And we do have an opportunity, I think, at the moment to really move things forward. It's fantastic to see student groups like this getting together to try and discuss this and move this whole dossier forward. So there we go. I'll leave it at that and come back later on. Thanks.
Awesome. Thanks, Dr. Allison. Next, we'll go to Dr. Quinones for a brief introduction.
Thanks, Dempsey, and I'll echo everybody's comments thus far. It's wonderful to see student groups and to see the Coalition for Dental Care continue its good work. You know, I think ultimately, the more people are talking about this, the better. I'll also agree with Mario that you know, we need to sort of think about this in the context of oral health care, and I'll push it further to say we need to think about this in the context of health care, as well as healthcare professionalism. So from my perspective, who am I? I'm a professor at the University of Toronto. I direct its specialty training program, so I train specialists in dental public health. I worked clinically for about a decade after graduation, mostly in the public sector, in a variety of contexts and geographic areas and so on, and stopped to really focus on my research and teaching. I'll also agree with Paul in the sense that we really don't have an oral health care policy. In fact, it's great to hear them say that as people that came to Canada from other countries, like I did, but I was only 8 years old, so it's a bit of a different experience. But you know, to be surprised that dental care was not included in our national system of health insurance, which we call Medicare. And I find this to be the case among many of my international health policy colleagues, that they're quite surprised when they realize how marginalized dental care is within our healthcare system. In a comparative sense internationally, it's quite an outlier. And I joke with them, sadly, saying, well, our oral healthcare policy is, well, brush your teeth, and if you don't, we're not going to do very much for you. That's probably a bit of an overstatement, but that sort of gets the discussion rolling on what our policy basis is. Just very quickly, two more things. Brandon mentioned two very important statistics, that 1 in 3 individuals don't have any type of dental coverage, and coverage is really, really important in order to be able to access and utilize dental care. About 1 in 5 say that they can't go to a dentist or visit an oral health care professional because of costs. And I was actually doing the math on that this morning, and that's actually upwards of 7 million Canadians. So it's a lot of people that we don't do a whole heck of a lot for. Across the country, it's Paul said it's a mess. I agree. I'll give it another term. It's like a patchwork of purpose, you know, and there are policies, but they're fragmented. Different programs try to do different things, target different populations. So there's a lack of, you know, sort of a unified focus on what it is that we need to do, and I think we're getting there. And you know, last to have groups like yours sort of talk about it and sort of get us thinking more in unison, I think is great. So thanks for having me.
Awesome, thank you, Dr. Quinones. And last but not least, I'm really very thankful to have Dr. Bruce Wallace join us today, who was recommended by Dr. Leanne Donnelly and Dr. Brondani from UBC, who added a very, I think, unique and refreshing perspective. So I'll pass that off to you, Dr. Wallace.
Thanks. Yeah, so my name is Bruce Wallace, and as we start, just want to acknowledge, as we talk about Canada's dental policy and practice, that we're doing that on traditional Indigenous lands that are most often unceded lands. I'm on the Quinion territory, but just also the role that we're locating this discussion in the history of health sciences, health services, including dentistry and colonization, and looking at how we move, as we've been talking about how to integrate dentistry and oral health more into healthcare policy, also how that's linked to systemic racism in healthcare that is widely acknowledged for Indigenous and BIPOC peoples in healthcare, and we would assume that that's also would continue into oral healthcare also. I think that I would like just to build on, my background is in social work, and I came into the issue around access to dental care as a sort of a phrase from the issues from working on poverty, around homelessness, substance use, mental health, but mostly poverty, and seeing it as a poverty issue more than a healthcare issue. And then learned a lot from many of the panelists here, and was able to pursue some of my learnings and research at UBC Dentistry also. As many people have already said, there's almost an absence of oral health policy, and it's not well integrated within healthcare, but also within social policies. And so I won't reiterate a lot of what's already been said, but just to build on that is I think it's also around the practice, the services. And so we also have the predominant model is around private practice dentistry, and most of the oral health care is delivered through business models like private practice. And so I think when we look at how are we going to move forward, it's around the policy and public funding, and it's also looking at alternative service delivery models. And so what I've been most involved in is around community dental clinics and how we can pursue health equity by assuming that we want to actually have tailored services to respond to different social determinants of health and different equity interests. And so that's, I want to sort of focus a bit more on that and contribute in this discussion. Thanks so much.
That's awesome. Thank you, Dr. Wallace. It was really nice hearing your background and experience and how you kind of are connected to this topic. I guess we'll kind of dive into the questions now that we've done some brief introductions. Like we said, we're hoping to keep this kind of as organic and fluid as possible. You're welcome to kind of chime in here and there as your colleagues mention certain points, and also, like I mentioned, if you don't feel there is anything you can add to the question, or you maybe don't feel comfortable, that's totally fine. You're always welcome to pass. So the first question is, how does dental policy change from municipal to provincial to national level what dental public health programs are specific to your province and please comment on their effectiveness and areas for improvement from your perspective. So hopefully we can kind of get some province specific perspectives and an outlook on the programs where you currently are. So I guess we'll stay on the West Coast, and we'll start with Dr. Brondani, if that's okay. And I'm always happy to repeat the question if needed.
Sure, thank you. I would just correct myself. We are actually presenting coast to coast here. I didn't know that we have a fellow from Newfoundland, so it is quite national. So kudos for you guys to organizing this. Yeah, so perhaps Bruce and I can share what we know from BC here, but perhaps as many other provinces, British Columbia has 5 health authorities and the First Nations being the 6th one. So that means that each authority might have different programs that are not necessarily the same as any other province. Any other authority. At the same time, might be different than Canada, right? So what I do know is some authorities focus on children, for example, low-income children. Others focus on pregnant women, depending on the area that they are located. So that's more like in terms of programs that they offer. In terms of, I think as a province-wide, and probably like others, we do have specific programs, perhaps as a translation of a policy to particular groups, and I think that echoes what other provinces might experience. For example, disability insurance here in BC, or if you are in welfare, you get $1,000 every 2 years, which, as we know, doesn't go too far. If you're a child from low-income families, you get $2,000 every 2 years. But again, given the needs that we seeing children from underserved communities, $2,000 don't go as far. We also have some specific target programs for refugees, for example. But for me, when I was asked to participate on this panel, I mean, kudos for the students again. You folks are doing an excellent job, and I think if we start at your training during undergrad, we are already doing some changes here. So advocacy there is a big thing here. But then I kept thinking about universal access to oral health care. Honestly, I'm very cynical when it comes to this, and maybe I might be a devil's advocate. Universal for me, for example, I don't need dental care. I have a very good plan under my employer UBC. So why spending perhaps thinking and a gigantic budget that this could be to those that might not need as many as you folks just mentioned, at least 30%, I would say probably more than that. So I would put a question mark there, what we mean by universal to all Canadians, right? But second, one thing that we encounter here, myself as a practicing dentist, is some of those folks that might be eligible for those programs, they sometimes are not even aware of those programs. So we spend quite a lot of time in the clinic actually liaising with the person and the program to see what kind of coverage we have. So perhaps I would let Bruce comment a little bit more on that. Is we are also not doing a good job in letting people know what kind of coverage they might get, even if it's minimal, and they are not using the system.
Yeah, building on Mario's, in most of the response to oral health inequities in BC is around the provision of public dental benefits. And those are currently linked to social assistance, so welfare and children and families. And so I think once we do that, like in other words, they're not in the healthcare system, they're in the welfare model. And in that, it's stigmatized. Welfare spending continues to be stigmatized, and it's seen that to be able to be progressing in provincially or nationally, we should be reducing dependency on welfare, and people should be economically independent. And so as long as we keep oral health spending in that envelope, I think it's going to be stigmatized and seen as a thing we don't want to spend on rather than spending. We need to be moving it more into healthcare. But also I think, and Carlos has done so much research on this that really shows that it's where the needs are, and that there's a gradient of need in Canada, and that it's not just that it's not just like there's a certain groups that have like these core needs that exist, but there's also this gradient. And I think that if we want to start reaching people who might not be receiving social assistance, like so many low-income earners who have no access to employer benefits and have no welfare benefits through social assistance, then we need to be able to move some of the access to public dental benefits more into like just the regular tax system or regular healthcare, our BC health card model, so that people who are recognized as having lower incomes and facing barriers to cost, if it's through pharmacy, you know, for prescription costs or whatever other costs that are privatized in our healthcare model, that dentistry is in there. And so I think that when moving in public policies, that's where I think from my experience in BC, we could be looking.
Awesome. Thank you to our colleagues from the West Coast. That was nice to kind of get an outlook into what things are like there. I guess following the original order, we'll hop over to the East Coast now and go to Dr. Doucette.
Sure. Yeah, so just something to add, I wanted to mention about what was previously talked about having a large budget for dental care in Canada. And I think something that often gets overlooked is that we already have a massive budget for dental care in Canada. It just goes through work-related plans and out-of-pocket payments mainly. Mm-hmm. So if we were able to shift that through our tax system, I think we could use those resources more efficiently than the way we currently do. And I just wanted to briefly talk about how we can learn from the lesson with our public healthcare system to try to improve standards for dental care in Canada. And it's important to remember that both the provincial and the federal governments have a role in funding healthcare. So the provincial governments obviously have a role with administrating services, but the federal government can also set national standards as a precondition to help provinces fund healthcare. So, you know, these national standards follow principles like comprehensiveness, accessibility, portability, universality, and public administration that actually have legally binding mechanisms in place to help enforce some of these principles. And a major problem with dental policy in Canada is that there are no nationwide standards. And if we were to actually put dental care, you know, under the tests that we put healthcare under, we would fail it. So I believe the federal government can act in a way to basically provide funding to provincial governments under the precondition that they meet certain standards to help ensure every Canadian has access to quality dental care.
That's a really interesting idea. Yeah, I definitely like that. I think next we will go, we were with Dr. Allison in Montreal.
Okay, thanks very much. And I think I'm going to build on a lot of what's already been said. In Quebec, as I'm sure many people know, there's the so-called RAMQ system, which is the medical system, and dental care for kids until their 10th birthday is part of that system. And so it's essentially part of universal healthcare, which is fantastic. I strongly believe in that model, universal healthcare, because it makes access so much easier for everyone, both from the user's perspective, the patient's perspective, and also from the provider's perspective. It's very straightforward compared to, as I was talking about, the mess, or as Carlos was saying, the patchwork of programs, or as you've heard, you know, when we were listening to Mario describe what's going on in BC, and it's true in many other provinces as well, where there's this range of different things going on for different groups of the population, and many people just don't understand that, you know, really struggle to understand that. Whereas if you have, say, it's part of the system, then you can move on and you can decide, well, you know, it's part of the system. What do we mean by it? What dental care, what oral health care will we provide within that system? And I think we can get into all sorts of discussions about that sort of thing. But basically, that means that whatever we're deciding would be within that system, everyone's got access to it, which makes it much easier. And then you think about who's providing the care in that system, and we can be much more flexible. We don't have to think about just about dentists. There are all sorts of people who are already really concerned about oral health care on the medical side, whether we're talking about pediatricians and pediatric nurses or geriatricians, and then we can go on, as well as all sorts of other groups. So I think we have the model. We don't have to look very far. We already have the model. Of course, we can always criticize models, but I think we already have the medical model that we should be looking at fitting into. If in Quebec, the additional elements that we have is we have a network of public health dental hygienists who can go into centers for the elderly and provide sort of screening services. They can go into schools for screening services, that sort of thing, which is fine, but it's pretty limited. And that's really that's basically it, apart from a few you know, exceptions mainly linked with dental schools as well. So to come back to your question, I think we have the answer of the way we can move forward, in my opinion, already here in Canada, and we just have to see how we can best integrate oral healthcare into that general healthcare system, and that goes with what you know, Mario was saying about we should be thinking about oral healthcare, and then Carlos was saying we should be thinking about healthcare. Many of us in the dental world believe strongly, certainly I do, that we should be much more integrated with the whole range of our medical system colleagues, not meaning just physicians and nurses, but the whole that whole group of people who will work in community centers providing all sorts of health and social services. And it'd be much better if we were basically part of that same system, being paid in the same way, et cetera, et cetera.
Awesome. Thank you, Dr. Allison. Yeah, I think you guys touched on quite a few points, and one of our future questions will kind of allow you to elaborate a bit more on that in terms of the various places where this has already been achieved, and kind of how we can learn from these countries. But I guess last but not least is Dr. Quinones.
All right, so you know, lots of good stuff already, and we could go into a lot of areas, but I'll start off by answering sort of the original question, which was, what does the system look like? Well, there's just in terms of Canadian governance, you have a federal government, provincial and territorial governments, and then municipal governments. At the federal level, they cover a variety of groups, but the groups that really fit into, you know, quote unquote, public dental care are state recognized Indigenous persons, which are First Nations and Inuit, although there's a lot of variation in there. And what's excluded generally are the Métis. That's a whole other webinar. Then there's refugees, and that's very minimal coverage. And then there's people in federal penitentiaries. Then when you go to the provincial level, in general terms, or provincial territorial level, in general terms, these jurisdictions focus on welfare recipients, as has already been discussed, on children of low-income families. They tend to get the most. Some provinces and territories that do something for low-income seniors. And then mostly on the welfare side, and I'll talk about that later on. Very good insight that Bruce had. And then when you go to the municipal level, there are some municipal programs, and that speaks to what Mario was saying about the variability. And when I say municipal, you could also say regional, as Mario was speaking about it. In general terms, though, by placing so much of the services on the welfare side, it becomes very stigmatizing. right? That's why we focus so much on low-income children, because we can't hold them responsible for the lot in life. But if you're a low-income adult who doesn't have the type of quality job that we think is appropriate, or doesn't have a job at all, oh my goodness, clearly that's a moral failing. I mean, obviously, I don't mean that, but that's kind of the sense that you get, which is reflected in the amount of money governments are willing to put in. And that's actually also reflected in the way dentists view publicly insured populations. But if you were to switch it to the healthcare side, you know, there's still stigma. Bruce spoke about it earlier with respect to Indigenous individuals, significant stigma in the healthcare system. But in general terms, there isn't that stigmatization if you're low income in the healthcare system. You know, I'm sure many would debate that, but just, you know, in ideal terms, that moralizing of your health status is you know, I would hope for the most part absent. So it makes things a lot easier, because it's attached to this card that you may or may not have, but it's attached to something that you have as a right of citizenship, which again makes it quite easy or easier. So that's generally the way the system works. And I just want to highlight a couple of other things which is important to contextualize discussion. If you have one dental care dollar in Canada, only about 4 to 6 cents of that is actually paid for by governments, which is, you know, like, we're a complete international outlier. The US actually pays more of that dental care dollar publicly than we do, right? And that is often a surprise to many. But if you go into those 4 to 6 public cents, 2/5 of that are covered by a federal budget for state recognized Indigenous persons. So a huge swath of that money is gone immediately in the context of the federal fiduciary relationship between the federal government and indigenous groups. And then after that, it's mostly low-income children. So again, small potatoes. And I also agree with Brandon that there's a lot of money in the system. You know, we're close to about $15 billion of spending on dental care every year in a relatively inefficient system, right? I mean, it targets people like Mario, and I'll make assumptions here. I'm assuming Mario doesn't have a lot of oral disease and doesn't need a lot of oral health care. But yet, everything that's in place from a subsidy perspective, whether it's through taxation treatment of dental benefits or just the ability of people to access the care, it's all targeted to people like Mario, people like myself, like Paul, like Bruce, you know, because we have these relatively generous employer-sponsored plans, and there's almost nothing for the people that need the most, right? That's kind of very regressive, very, I'll almost say perverse. What I will say though, and this is, I'll pick up on Mario here in terms of being another devil's advocate, is that the idea that everything will be solved by putting into Medicare, and I don't think that's what panelists are saying, but I think we need to be more strategic politically. What do I mean by that? I am completely on board with universalism, but I would like to focus us on not universal dental care, but the universal coverage of dental care. And we'll talk later on how there's many jurisdictions around the world that achieve universal or near universal coverage in some pretty efficient ways that don't just mean statutory health insurance with a single payer. Now, I'm not saying that's a bad idea. I support that idea, but I think we need to be more strategic in the context of Canadian healthcare governance, in the context of the politics of healthcare, dental care, you know, so on and so forth. And I'll end by this, something that Brandon was saying with respect to the federal government having some type of policy leadership role in terms of setting national standards. I think that is a wonderful mechanism by which to, at least instead of this patchwork of purpose or this mess, getting different jurisdictions on the same page in terms of an approach that is non-stigmatizing, that promotes universality, you know, so on and so forth. So there you go. Thank you.
Awesome. Thank you very much for adding very much to the context and kind of also giving that breakdown from the federal to all the way down to municipal level for our viewers. This next question is a little bit long-winded. I think this might have been your question, Ziad, so you may have to provide some clarity if needed. So I'm just going to go through it. So given the failure of present dental structures or systems in place, example, fee for service, for profit business models for delivery of dental services to vulnerable Canadians, and the significant gap in payment for procedures between private and public dental plans, which creates a disincentive for dentists to treat those most needing essential dental care. How do you see policymakers and health ministries moving forward to embrace or encourage the creation of salaried dually trained providers, meaning dental hygienists, dental therapists providers, who would work in public health settings with a focus on upstream prevention, interventions, as well as regular essential dental care for marginalized populations? And the last part that kind of, I guess, hits this question home is how do the panelists see a way to break the monopoly of organized dentistry and its self-interest lobbyists while holding governments accountable for underfunding or eliminating public health programs necessary in many areas where dental care could be accessed? So I know many of you have kind of already touched on this, but if we could add more to this specific part, I believe we'll start with Dr. Brondani, if that's okay. And like I said, you're welcome to kind of organically pick up wherever you'd like if you have a thought come to mind.
Thank you. Yeah, that is a long question. Yeah, when I was reading that, I was debating myself. I think that's one idea if you're talking about prevention and cost. Cost to train a hygienist or a dental therapist is lower than training a dentist. So I think that is one option. I don't think it's one size fits all at the same time. And we do that in BC, I believe here. Most, if it's not all, of the oral health providers that work in the public health system are hygienists. We don't have dental therapists as many as we should have. As we know, the school is no longer active, but I understand that maybe it's coming back soon, I believe. So that's one way of to go. The other, I think, within those professions is the scope of practice. There is a lot of discussion about what one can do, cannot do. I'm still mesmerized by the fact that people still question whether or not, for example, vaccines could be offered in a dental setting or a hygiene setting. Come on, we inject people with things in their mouths. A vaccine is just nothing compared to all those things. But anyways, that aside, I think we need a mindset change here. And for me, that starts at undergrad level, educating the future providers on how to advocate, how to challenge things that come their way, and they say, let's think outside the box and let's do other things here, for example, right? So, and that's one frustration for me as an educator at the university is here comes Mario talking about public health, and yet 99% of our grads go to private practice. So it's a catch-22 though. It's we don't have that offer for them to work in private practice. So at the same time, I'm here to advocate for that. So it's a lot to go, I think. But salary is one option. Again, I don't think it's the only option. And it comes from us, from those that are quite minded in terms of questioning the system as it is now, and say, let's move beyond this. And as we heard already here, we don't need to reinvent the wheel. I mean, there are other countries that are doing that might have achieved, Carlos mentioned, the universality in terms of the concept of the word. We also do, as I was mentioned, like $12-13 billion are in the budget at this point. So perhaps is having a discussion about willingness to change the mindset of the system as it is now.
That's great. Thanks, Dr. Mario Brondani. And next, we'll pass it off to Dr. Sorry, I believe we're changing it up a bit, but I think the next one was Dr. Doucette.
Yeah, so there's a lot to tackle in this question, so I'll try to kind of break it down as best I can. But to start off about kind of holding governments accountable for underfunding public dental programs, I want to talk a little bit about the politics of targeted programs versus universal programs, which has already kind of been touched on. But targeted programs help poor, marginalized communities. So it's easy to demonize these programs in the people who rely on them as getting free stuff. So governments can more readily cut fundings for these programs, cover fewer procedures, and de-index the fees they pay out from inflation. So this is a big problem because dentists will often then not accept people on these programs, and there's a lot of stigma associated with this. Whereas with universal programs, everyone buys into them. So cutting funding for these programs is very much seen as an attack on the society as a whole, and there's much broader backlash, and it's harder to do. So in order to create a sustainable public dental care system, I think it's important that we embrace a politics that can actually stand the test of time. And to kind of move on to another part of the question, because there's a lot to cover here, is that it is important to remember some of the historical context towards programs like universal healthcare in Canada, and understanding that doctors were the biggest opponents to universal healthcare in Canada. So like, in order to overcome some of those barriers, we do need grassroots movements, popular pressure, which is really what we're trying to do with Coalition for Dental Care, to help try to overcome some of those moneyed interests that really want to keep the status quo the way it is. So when we're building that public pressure, I think the dental therapy or dually trained kind of dental hygienist dental therapy model, along with public ownership, is a really exciting opportunity and a way to build on our universal healthcare system, not just an insurance-based system. So one of the things, when we talk about a dental care for all plan, like we do with the Coalition for Dental Care, it's really popular, but people have some hesitations. And the hesitations I tend to hear from people in the public or policymakers tend to be centered around, for one, the costs, and also, like, just because you have insurance doesn't mean you necessarily have a dental provider to provide that care. So I think the dental therapists working in publicly owned clinics is a great way to meet both of these demands in an organized, efficient way. So dental therapists are, for those of you who don't know, are dental providers that can perform simple procedures like fillings or simple extractions at a fraction of the cost of a dentist. So there's a lot of, you can make your tax dollars go further in that sense. And also having dental therapists work in places like, say, schools or long-term care facilities, community and Indigenous health centers, prisons. These are all ways to meet the population demands, particularly in places where they currently lack access to dental care the most, in a very efficient, effective way.
Awesome. Thank you, Dr. Doucette. Yeah, just quickly chiming in from Saskatchewan. Yeah, the dental therapists used to and still do play, not quite as much, but a massive role in providing care to under-accessed northern and Indigenous areas. And yeah, I'm really looking forward to hopefully seeing that school become reactive. I believe next it was Dr. Allison, if you'd like to add to the discussion for this part.
Sure. So yeah, there's a lot to one could go in all sorts of different directions. So maybe I'll just sort of focus on 2 or 3 ideas when reading through this question, and building on what Mario and Brandon have already said. I think I agree 100%. We need to be flexible. I'm all for having salaried providers. They're at different levels, but I think we should have a range of models that best serve the community, and we should be we should be thinking about this in terms of the needs of the population and the groups that we're trying to serve, and we need to be making our services patient-centered, community-centered, population, however you want to define it, centered on them, centered on their needs, and how best can we provide the services. And so the examples that Brandon was just giving of having a therapist in a community center paid with a salary, et cetera, is going to work very well for many, but it may not work so well for others. and it depends what the needs are and whether the therapist can fulfill those needs. But I'm sure they could fulfill many of those needs. But for instance, that's not going to work for people with Alzheimer's in their centers, and we have to think about those groups. And there's all sorts of other groups. I think, in the First Nations, I don't pretend to know anything about the needs of First Nations peoples and the way they would like to be have their services provided. And I think we need to be asking them what are their needs in terms of oral healthcare needs. How would they like to be served? And so we should be focusing much more on people and then saying, okay, so we gather the data and we then say, okay, fine, they need this. These are the sorts of providers that could do that, whether it's nurses, physicians, therapists, dentists, hygienists, whatever. And given the need, is the need very much focused on treating disease, or is the need very much focused on prevention, or is the need very much on trying to integrate their oral health care with their general health care with people who've got lots of other chronic diseases? There will probably be a better model of compensation for those different sorts of things. So that makes it much more complicated, which, in my mind is a very good argument for, fundamentally, it needs to be within the universal system. And then after that, we need to think about how best to provide the service that's centered on the people that most need it. Rather than the model we have at the moment is, I'm a dentist, I'm going to set my office up in a place where people can afford to pay for my services. And I can, I'm not saying that, I'm not blaming a dentist. Anybody who sets up a small business is going to go to the place where people can pay for that small business. And that's perfectly reasonable and respectful. But it means the people who can't get to them, they won't get there. So that's why we need to go back to the universal system. So, that's my thinking on that. And we need to gather data on what the needs are. And that's something, that's talked about a lot on many, many different levels, not just in Canada. The horrendous lack of data that we have about the oral health and oral health care needs of whether it be Canadians or Americans or Europeans or Mongolians or pretty much anywhere in the world. The data is very poor. Yes, we have surveys here and there, whatever, but we don't have, in the way that health data and healthcare data and health needs for healthcare data are collected in a much more systematic way. That's part of us being part of the system as well. At the moment, we're setting up a system where we're going to do a survey of Canadians in the next year or two to find out more about their oral health and their oral healthcare needs. The last time that was done by the federal government was in 2007 to 2009, and before that it had not been done. It was the last time it was done was in the 1970s. So it's ridiculous. So there we go. Sorry, it's a bit of rambling, but it's a rambling response to a rambling question. There you go.
Thanks, Dr. Allison. Yeah, that was great. I definitely agree with a lot of your points there. And I think it's definitely critical to involve those marginalized populations in the decision-making process, because right now, I guess we're basing it on wrongful assumptions. But next, I believe, Dr. Quinones, if you'd like to add to the conversation, please.
Yeah, poor Ziad here is getting lit up with this question, but I think it points to some very important things, like really important things, actually. So props to you, Ziad. So I'll answer it sort of in to provide some type of framework for discussion if it's useful. So I think we need to think about how dental care is organized. And by organized, I mean, how is it governed and how is it managed, right? We've addressed some of this stuff, public, private administration, a federal role in its governance, so on and so forth, just like in healthcare. We also need to think about how it's financed, which means who pays for it and how it's paid for. So right now we have a mix of payers, mostly focused on the individual and family and the employer relationship. You know, clearly there's much room for improvement there. And then in terms of how it's paid for, you know, many years ago, I did a survey where we asked dentists if they were willing to consider anything other than fee for service, you know, salary, capitation, or per person payment. There weren't many options available at the time in terms of how we were thinking about it from a policy perspective. But like 99% of dentists said, no, I want, you know, my fee for service payment. But now, more recently, there's starting to be a bit of a revolution in thinking about how healthcare providers are paid to incentivize good health outcomes. Meaning, the conversation is moving from how many services can you do per given unit of time to demonstrate that you're actually improving people's oral health or health. And this, by the way, has, to me, from my perspective, has the potential to shake things up far more than anything else that has been discussed here, and I think could drive many of the nice policy innovations that are being discussed in terms of shifting things a little bit more towards the healthcare side and so on. Then we need to think about how dental care is delivered, meaning who delivers it and how it's delivered. The who right now is homogenous, as some of the panelists have said. We're really functioning in a handful of providers in a private practice on a fee-for-service basis, which we've already touched upon. But there's other ways, you know. Canada had the dental therapist for many years. Dempsey, I'm glad to hear you say that you think it's some type of robust activity. My dental therapy colleagues sort of want to, you know, punch me in the face every time I talk about this, but it's on its last legs. And to hear that your school in Saskatchewan is making a really significant, important run in partnership with Indigenous groups and community and the community college, whose name escapes me for now, but to bring it to fruition again, to sort of, you know, raise it from what I perceive, you know, a pretty serious state, I think is wonderful, because it matches what's increasingly happening in the US, that where policymakers are running in this direction. Meaning we need far more heterogeneity in all of these areas, right? Because that makes the system healthy. I'll also say that, you know, forget about dental care and Medicare, but the idea that everybody, by right of citizenship or right of being in the country, forget about citizenship, has access to some type of public coverage. To me, that's, I don't want to call it easy. That would probably be very politically difficult. But to me, that's the base case. That's how you make it part of healthcare. And then people like Mario, people like myself, you know, so on and so forth, or maybe Paul or Bruce, you know, it's like, no, we like our employer-sponsored plan, so we can opt out, right? That's one option. Or, and we're going to talk about this later, you do it like other EU nations, where you structure the universal coverage around the employer-employee relationship, which means every employer has to provide it, no matter whether you're, you know, a Fortune 500 company or you know, a store that let's just say this, a dental office that employs like a handful of people. Now, it's going to be much harder for a small business to do it, but that's where the public subsidies come in to support that type of environment. And there's systems in the world that function like that and do very well. I'll also end off by saying that, you know, this question sort of starts from this notion that the oral healthcare system is failing. It depends on your perspective. Like, I've spoken to some economists that say, man, it's an incredibly efficient system. And I'm like, what do you mean? Well, utilization rates among children are at about 80 to 90%. Utilization among the general population is about 70% or a little bit more, which, by the way, beats utilization in many nations, right? Most people don't have any cost prohibitive dental care needs, right? Because 1 in 5 people not being able to access the dental care because of cost also means that 4 out of 5 have no challenges. That's too simplistic, but there you go. Going back to what Paul said about the Canadian Health Measure Survey in 2007, 2009, that looked at what people's clinically determined treatment needs were. I mean, you're looking at about less than 1 in 5 individuals there having any major oral health care needs. So depends on your perspective. Now, my perspective is if you're looking at equity outcomes, meaning differences in the outcomes between rich and poor or social groups, whether based on education, income status, and so on, then we're a bit of a train wreck, right? Because then we actually have some of the widest gaps between income groups, for example, around the world. So in that sense, the dental care market, our system is incredibly inefficient and is failing a lot. So I think we need complex solutions that are ultimately matched to complex problems. But as a base case, that idea that everybody has coverage for some basket of services in a public context, and then maybe you can opt out or whatever, I just think that provides some direction to thinking about things like how dentistry is organized, meaning how it's governed and managed, how dentistry is financed, meaning who pays and how it's paid for, and then ultimately how it's delivered, which means who delivers it and how is it delivered. I like to push those ideas because I really do think we need to simplify what is ultimately an incredibly complex landscape.
Awesome. Thank you, Dr. Quinones. And Dr. Wallace, is there anything you'd like to add to what has been said?
I think just to highlight again this alternative service delivery models, and so how so for here in Victoria at the Kool-Aid Clinic, we're integrated within the community health center, so it's focused on inner city medicine, and the doctors, the GPs there, so in the universe and in healthcare, they're salaried in the community health center, and in the dental clinic, the dentists are salaried. And it's a model that we think is really important as part of the mandate of community health care and community dental care. And I think it works. I think there's challenges, but we also know that in our setting, there's a high rate of no-shows. And so when somebody's getting a per day rate of pay as a dentist coming in, they don't have to worry about the chair being empty and losing fees. So it works both ways in some ways. I think what I've learned over the years is that I think it's naive to assume that private practice dentistry has a mandate and can fulfill public health goals or the public health mandate around oral health care. And I've also come to think that the major lobbyists for oral health care or dentistry also don't, it'd be naive to think that the dentistry lobby is going to respond to the public health needs also. I think that their main goal, mission, or mandate is to represent their membership, and the membership is private practice typically, and they need to make. And I think that that's fair. And so, but I think it's naive for me to assume that these groups in nationally or provincially or regionally are going to take this on in a way without that they have to make sure they're also making sure that the priority is the membership and not public health. And I think that they do really great work, and they've been able to achieve both in many ways. But I also think that we need to focus, as Brandon said, on like the Coalition for Dental Care, and then also for the group a lot of us have worked with, also the Canadian Association for Public Health Dentistry, that there is roles out that we should be really trying to function in and work outside of the professional associations also.
Now, just maybe changing a little bit the routine here, and since Bruce opened a can of worms, I would like to open another one. And for me, though, is and I think Paul mentioned a little bit about that, is the patient side of things, meaning hear what they need. And I can tell you that most of patients that I see, they do not care less for oral health because their lives are so messy. They have a survival mode that taking care of teeth or gums is the least of their concerns. So we cannot talk about oral health without talk about basic income, without talk about poverty reduction, because trust me, it can be universal, it can be the best model ever. People might not come to you because they have other things in life. So I think we have also to be mindful of the patient side of things. And a classic example that I give to my students is this. I went to a political discussion with the major parties here, meaning for us is the NDP, which is really a liberal party, but NDP, the Conservatives, the Greens, and the Liberals. So they were putting for their policies, and was in this case was targeting older adults. And I am a geriatrician. I teach geriatrics in dental school here. So I went there, and none of the audience asked about oral health care, none. And they were talking about access to different services. So yet, if you think about the need of an older adult, it might not be the same as us in our age, but that's beside the point. Nobody asks for better access to oral health care because it's not under their radar, either because it's lack of education or because they are not aware of the needs. But anyways, I will let Carlos continue on that one.
Dempsey, please, as moderator, tell us to shut up if we're not following the script here. But these are all the really important issues, and I see lots of questions coming, so I'm just going to go for it. I very much agree with Mario and what Paul just said. So let me put it another way. I think we need to really focus on a person-centered care system. Like, forget about, I don't want to say forget, but it's like, the question should ultimately be, what is that patient or what does that particular group or population of individuals need? And I think they will have different solutions based on organization and management, based on financing, delivery, and so on. The other thing I want to highlight what Mario said, which is really important, is that we very much care about oral health care, but some patients who need it the most may not. Some groups that have a lot of political power, like let's just say seniors in terms of their lobbies, which can be quite powerful, they may need it a lot too, but that's not the things that they go lobby for. And just this past Thursday, I heard a very, very senior academic who's also a lobbyist in the US and Washington, very public health focused, equity focused individuals, super, super brilliant, talk about how we are never going to make dentistry a major public policy issue because it's too niche. And those were his exact words. So he figured out early on that he tried to tag it along with what legislators cared about, meaning he used several examples to the geriatrician issue. Legislators cared lots about healthful aging. So he joined a lobby that was about healthful aging and added the oral health care voice or the oral health voice. Lobbyists cared about, the major non-communicable diseases or chronic diseases. So he added himself, demonstrating how oral health and oral health care had significant implications in the context of those diseases. And he said that he found much greater success in moving his agenda forward by doing that than just showing up in the context of, hi, I'm oral health, hi, I'm oral health care. And some research that we've done in the past, again, it's a little bit old now, so I don't know if it would hold in today's civil society and environment. But many years ago, we asked individuals, let's just assume the government had money to spend. Where do you want to see it spent? Childcare, pharmacare, home care, vision care, dental care. And we asked people to rank them. So what's your first choice? Okay, what's your second choice? Dental care was never a first choice at any level of choice making. So it was never number one, it was actually never number two, and it was actually never number three, and so on. It always ranked as the third choice at every level of choice making. Does that make sense? So if you were to rank all of people's first choices, dental care ranked third or fourth. Everybody's second choice, dental care ranked, So just to strengthen my argument that we need to become more sophisticated in how we lobby, and in order to move this agenda forward.
Yeah,
Awesome.
I think what, just going with Carlos says, like, if people, as long as we have this housing market and people can't afford their housing, I don't think I don't think increasing public dental benefits is going to help. When people can't afford their housing, they're not going to make dental care overpaying rent. It's never going to reach it. So I think that it's that's how it's linked to poverty, and a really hard nut to crack.
Thanks, Dr. Wallace and Dr. Quinones. Yeah, no, those are very good points, and thanks for sharing what you heard. I think that's definitely something to consider. Even just kind of quickly sparking in my mind, I haven't done too much research, but I've helped with a few grant applications, and just seeing where the government's, like the federal government's kind of priorities lie, healthful aging and those related things. It kind of just shows what their true intentions and priorities are. And yeah, certainly dental care is nowhere to be found, which is a major issue. I was just speaking to Ziad, and just for the sake of time, fortunately, I think we are going to skip number 3. I think it's kind of already been covered to a large extent, but if you did have something you really wanted to mention, you're free to kind of intertwine that into your answer. And also, if someone does have to leave, if anyone does have to leave, if you have somewhere to be, please feel free to. We're not forcing you to hang around or anything. But I guess we'll skip to then number 4, which we kind of have alluded to a bit, but I'm interested to hear some specific examples if anyone has any. So which countries or healthcare systems can we look to for precedents and learn from when evaluating and developing new oral healthcare policy in Canada? So I guess also, like Ziad also mentioned, I guess we can kind of go organically. If someone wants to start off, you're welcome to kind of just chime in. If not, then I can call upon someone. If anyone wants to start off.
Brandon, go ahead, sorry.
I just wanted to say that this year, I believe it is the 100th anniversary of the New Zealand Children's Dental Program, which is a school-based dental plan where they use dental therapists. And it's a very successful model. And there's been a cost analysis of this in Canada by the Canadian Centre for Policy Alternatives. And I think this was done around 2010, and it was estimated to cost a little over $500 million a year. So considering we spend about $15 billion a year on dental care, $500 million for a national children's dental program is very reasonable. And I think it's something we should consider. But also, as I've mentioned before, being bolder than just the school-based model. So also looking at long-term care facilities, community and Indigenous health centers, prisons, places like this. I think dental therapy has a huge market to help meet population demands.
So I'm just going to quickly jump in, and I'm actually then going to ask Paul, because he has tremendous knowledge of the UK system, given that's where he's from. And then I really want to hear from Mario, given his significant knowledge of Brazil. And I'm sort of trying to throw up lobs because I think those two systems have really good things to offer, but also show some potential weaknesses. So my 2 systems will be, just because I've been studying them a little bit, is the German system, which is really focused on the employer-employee relationship, meaning most healthcare is provided in the context of employment. But at the same time, significant subsidies are given for those groups that don't fall within that traditional relationship. But for the most part, it's most of the population, right? So there's avenues there. Then I'll quickly move over to Sweden. Sweden is highly privatized, but enjoys significant public subsidies. So even though all the care, all the money moves around privately, it's essentially ultimately all public money, right? So without going into too much detail, but I'll just say, and actually Mario has some good knowledge about this as well, but they have what Brandon is talking about in New Zealand. They have a really rich and robust public dental service. Meaning in I think Sweden, I think it's now 23 years old, all dental care is fully subsidized for individuals under 23 years old. And then after that, you sort of graduate into the private system, where you still receive significant public subsidies. So I think there's many ways to do it to achieve universal or near universal coverage.
Awesome. Thank you, Dr. Quinones. I guess we can pass it off to Dr. Brondani. I think there was a direction there.
Sure. Yeah, I happened to spend my sabbatical in those 3 countries, New Zealand, Sweden, and back home in Brazil. So yeah, I mean, Carlos summarized that quite well. the Swedish system, it was quite interesting for me to get to know the system, although I focus more on nursing homes when I was there. And so they have a very nice mobile services. Mind you that some, if it's not most, nursing homes have a dental clinic inside each of the facilities, but those that do not, they receive mobile services, salaried dentists and assistants. So quite nice, but the thing that I was interesting to me to know about the Swedish system is, for some reason, up to 23 years old, and then as Carlos mentioned, as you grow older, you move along. There is an emphasis on prevention because if you don't have a lot to do, the patient still have the funding from that comes with it. So it's a benefit for the dentist to focus on prevention and minimizing the amount of work, because they benefit from that themselves. The Brazilian system, that didn't happen. So I left Brazil about 20 years ago, so we didn't have that back then. But now, is the government that employs the most number of dentists in the country. Mind you, Brazil produces the most number of dentists in the planet. Brazil produces 15% of the workforce. Brazil has 432 dental schools, which is insane and stupid. I'm sorry, I'm Brazilian to say that. For a population that is what, 300 million or something, so, or less than that. So yeah, but because they have so many dentists, and we say that at some point every Brazilian will be a dentist because it's so many dental schools. So the government employs most of the workforce as a dentist is to work for the government, and it's salaried. So they have the CEOs, they call is the Center for Specialties in Dentistry. So they have not just general dentists, they have actually perio, surgery, implants, you name it. And the patient goes into the system. But I want to bring something here that Carlos, I think Bruce and Paul mentioned, is the stigmatized idea that is a public system. So some patients do not go there because they feel that, no, this is just for poor people or people that don't have the means. So there is still a little bit of that in Brazil. Mind you, I don't have data, so that's what I heard from the academics that I know there. But again, so here you have, and even New Zealand, as Brandon mentioned, so you have three kind of different systems in a sense, bits and pieces of good things in some and not so good things in others. But in Canada, I think, if you look in special places, I mean, in particular places, we already have models that are similar to that. We already pay salary dentists. We already have the dental therapist. Maybe it's a matter of expanding that to a more national level, perhaps.
That's great. Thanks, Dr. Brondani. And next, we'll pass it off to Dr. Allison, if there's anything you'd like to add to the conversation.
Well, not much really. I mean, I think, as I said, to build on what I said before, I think we should be very patient-centered and community-centered and population-centered on what are their needs. And so I think we should be working with those groups in this country. And there are already, as Mario just referred to, all sorts of answers in this country within the very broad healthcare system that we have. And yes, we can see a few ideas here and there elsewhere in the world for what may work best for a particular group, providing a particular form of treatment. And again, I think it's really important to understand that it depends what the range of the needs are. You know, one of the other really big problems, for instance, with the private system is that it lets specialists set up wherever they want to be set up, and you know, anyone can be a specialist, and we have far too many specialists in many ways. You know, dentistry, you know, it's much easier and more accessible if most people can, most oral health professionals can provide the oral health care required, and a patient doesn't have to be sent to somebody in a different part of the city, or 300 kilometers away, or somebody has to get in a plane, or whatever it may be, to come down south to be treated, etc., etc. We should be using much more sort of a system which encourages using primary healthcare providers in primary healthcare settings, and they're able to do the simple, effective, and efficient, and often relatively cheap care. There's so much in oral health care that is very effective and is actually not that expensive in the grand scheme of things. So these are the sorts of things I think we should be focusing on as we think about how to move forward.
Awesome. Thank you, Dr. Allison. And Dr. Doucette, is there anything you'd like to add?
I just wanted to add something quickly to what Dr. Allison and Dr. Quiñonez has mentioned, of just like what we're talking about with some of these plans looks very different than what we currently have. And we need to be smart in the way we market these things to the public to make these, because we're communicating complex messages, but we need to do so in an easily accessible way. So that's what I kind of see when we talk about including dental care within our universal healthcare system. That's trying to convey a very complex message to people who, let's say, might not read well, or might be, like we're trying to convey very complex messages in a very simple way. And I think that's a very powerful tool for people to know, I'm going to use my health card instead of my credit card for dental care. And those are very good marketing tools, even though when you get into the details of it, like what we at the Coalition for Dental Care is advocating for is not just an insurance-based plan, but also the public ownership, the mid-level providers, the salaried providers in certain instances. And just understanding that that's very, very different than what we currently have, and how we need to muster up a lot of energy from the public to really enact that.
Awesome. Thank you, Dr. Sett. I think that was it for that question, unless there's anything else that anyone wanted to add, just given time's sake. The last question here, I think this will be our last question. Like I said, just given the time, it's kind of specific for at least the Federation of Canadian Dental Student Association's audience, given being Canadian dental students, hopefully giving them some tools or suggestions on kind of how they can help. So what steps can we as dental students take for the implementation of an oral healthcare policy that is more accessible to everyone? If anyone would like to start it off, just it can be brief, just kind of leaving our dental student audience with some suggestions. Thank you.
I'll launch that if you want. So I think, first of all, like I said at the beginning, I think congratulations to the group of students for organizing this. And I know there's lots of other events and discussions that you're organizing, which is fantastic to see that, students are in the leadership of trying to push for change. So congratulations, that's a fantastic sort of step in the right direction. And then I think what students can be doing, and not just students, but I think we need to think of, we're students throughout life. It sounds like a bit of a cliche, but it's really, really true. When things move so fast and become so different, so quickly, we need to be ready to be trained and retrained throughout our careers. So then students and residents and others who are linked with schools need to be pushing very hard for the schools to really start to rethink about the whole training of dentists, dental hygienists, etc., and start to really think about moving the training in a much more to give the trainees, the learners, much more skills in what we call upstream strategies. When I say upstream, what I mean is prevention and health promotion strategies, disease prevention and health promotion strategies. These much more, the discussion we've been having today is a lot around the politics of dental care. And that's a very, very complex area, as Brandon has just referred to. And so for for students and residents in all the different oral healthcare fields to understand. They need to be trained about that. They need to learn about that. They need to be given opportunities to work in those areas. They need to do internships and those sorts of things. They need to learn how to lobby. They need to learn how to come up with public health messages that are going to work. So I think one of the best ways that students can help is to be going to the leadership of our schools. And I speak as a former dean, and I know that, you know, universities and dental schools are, and I think it's true of all professional programs, all professional, whether it's lawyers or doctors or dentists, they're very, very conservative. You know, there's this whole system whereby we have, this is the way it's supposed to be done, and then we have accreditation systems to make sure that's the way it's done. So there's this whole system which is built, which makes it actually quite difficult to change. And yes, small things get changed, and someone will come in and say that they've completely revamped the perio program, but essentially it's still teaching things. It's just different therapies in there. A real revamping is to say, well, if we want to have address oral health inequalities in this country, we have to deal with, as Mario and others were saying earlier on, we have to deal with the enormous inequities in poverty in this country. We have to deal with housing. We have to deal with food security. We have to deal with education. And that's the sort of upstream approach that we need to be thinking about. Yes, people still need dental care and other forms of healthcare, but they need a house, they need food, they need good education, they need birth control, they need all sorts of things like this, which are not directly, well, yes, they are in some ways, but you know, it's not so evident that they're directly linked with oral health, but they're incredibly strong determinants of oral health and the oral healthcare needs of the population.
Awesome. Thank you, Dr. Allison. Would anyone else like to add some suggestions for our dental student viewers? Yeah, for sure, Dr. Doucette.
Yeah, so I would just like to say, I think a great way for dental students to get involved is by joining an organization to help push for better dental care policy. Obviously, I have a bias in joining the Coalition for Dental Care, and we're happy to have more people help if they're interested. But what I would just say is that if people are atomized and kind of off on their own, thinking that we should have a better system, you're not going to be able to get as much done as if you form organizations where you're actually working towards specific goals together. You're going to be much more efficient in achieving those goals. So I think dental care in Canada is really something that, you know, there's no reason that in a generation from now, if there's enough people who organize around this issue, put in the work, you know, it could look very different in a generation from now. And it's something that I think we have to have a vision for what we want to work for and organize around that. And it's something that bold policies and, you know, things that have been done throughout history that we look at as, you know, great achievements, at first were always viewed as unreasonable, unachievable, but because there's a group of people who work towards that and really, you know, organized around that, those things were able to come to fruition despite being seen as unreasonable to begin with.
Thank you, Dr. Doucette. Anyone else want to? I see Dr. Brondani took off his mic. Like to add anything to that?
Well, just one in terms of voting, be sure that you vote for somebody that you think represents what you believe. So go after the platform of the person that you are voting in your jurisdiction to make sure that aligns with what you consider is the best thing to do. That's
a very valid point. Thank you for bringing that into context, the political aspect of it. Anyone else? I think if no one else has anything to add to that, if anyone has any kind of take-home messages or has Dr. John O'Keefe, for those of you who know, any final pearls of wisdom to add before we end off here, that you can feel free to do so. Thanks.
I'll follow you, Carlo. I'll follow you, Carlo.
Sorry, Dr. Okay, Dr.
You sure? Because I don't have a pearl of wisdom. All right.
I have an activist rant, so I'll end it.
Okay. All right. Awesome. So we'll end with the good stuff. I'll just say, Dempsey, that what you're doing here today is an example of what needs to be done. I very much agree with Brandon. Join the coalition, join the Canadian Association of Public Health Dentistry. Get involved in organized dentistry, and try to make change there. You know, younger individuals, by definition, I believe anyway, are more sophisticated, and the point is to be better, right? So you know, to speak on something that Paul said, you know, and also what Mario said, you know, vote or get behind stuff that is really, really important. For example, you know, an anti-poverty lobby, right? Super important. You know, high level prevention stuff, like, you know, why wouldn't we support a taxation on a sugar sweetened beverage, for example, a sugar tax? We know it works incredibly well for tobacco, and there's increasing evidence that it will work in the context of sugar. You know, for those dentists who want to really maintain the status quo, I say, listen, if you don't care about income security and about the health of labor markets, you're not paying attention. Because even if you want to maintain the status quo, you should really be trying to support things that support the employer-employee relationship in terms of employer-sponsored dental benefits. I mean, I'm being a bit cynical, but you know, if you don't care about you know, food marketing to children, I mean, that's what we're all about, prevention, especially for kids. I mean, these are no-brainers. So I think if you know, vote with respect to those ideas and get behind those ideas with some communal work, like has already been mentioned, I think we can ultimately achieve a lot. Oh, and I will, this is not an activist thing, but I once had somebody said, oh, it's so unrealistic. So reflecting a little bit of what Brandon said, you know, these changes that you're proposing, you know, how do you boil an ocean? I was like, one drop at a time, let's get going. You know, I mean, there's no reason why change can't happen.
So I think that this seminar, which I think has really been great, I think what it really shows for students and others is that our practice is political. And so I think that's the message that I think is really important. And so when I look at the current politics in healthcare right now that students are entering in, you know, we're seeing the systemic racism, the acknowledgement of systemic racism and colonization within the healthcare systems. We're seeing an overdose crisis that is just decimating communities right now from substance use. And then just the increasing economic inequities that we're seeing in the pandemic. That's, I think, where people are studying and what people are going to be graduating into. And so being really aware of those inequities. And then the second part I have on how to address the practices political is to step up and take a role, but recognize that charity is never going to be enough. So it's about doing charity, to get in there and do the hard work, but really with this really strong recognition that charity can also be a safety valve from this real change that we're all talking about. And so making sure that health equity isn't just about increasing access. That's not about equitable access. It is about how we're going to get equitable levels of care, not just relief of pain, not only extractions, but actual equitable level to basic dental care, and that we're going to have equitable outcomes, hopefully, in a way moving forward. So those are the things I would suggest.
A quick point to note, that is a great point there, because I think what we should be working for is a system where people don't need charity for healthcare.
Awesome, thank you. And anyone else like to add some final pearls of wisdom? Those are some great final remarks for the future of Canadian dentistry to kind of take and digest going forward. But if no one else has anything to add, I guess I just want to say on behalf of the FCDSA and the Coalition of Dentalcare, was very kind to collaborate with us for this event. Thank you so much for taking time out of your Saturday and kind of offering this insight. It's kind of, I wish it was kind of more widespread. I know we're speaking to some kind of key opinion leaders and top-notch kind of people in this field. So hopefully the information continues to be disseminated and becomes more widespread knowledge. And I think, yeah, there's a lot of value in what you guys have said today related to oral healthcare policy and hopefully what we can look forward to